Well, good morning. I just never get the chance to be in a classroom. I always expect everybody to go, well, good morning, Dr. Springer. Doesn't happen. Okay. Yeah, that's right. Thank you, Dr. Reeve. I appreciate that, showing my age. All right. Anyway, I bring welcome to all of you guys from the School of Nursing and also from the College of Health Science. Something happened this morning, and the Dean Dunnigan, is unable to attend, at least the first part of this, so I bring greetings from the college also. We're really honored this morning to have Dr. Mitchell with us from the Translational Research Center at the University of Washington. We had the pleasure of having dinner with her last night. It was really fun, and got my immediate questions answered about translational research. So I got the sneak preview. I think you guys will all really enjoy it this morning. Translational research involves, bringing our scientific discoveries to fruition much more quickly. It's on the NIH research roadmap. We need to be working on how we can bring our scientific discoveries to, at least from the bench to the bedside in healthcare, in a much more rapid time frame. We're really happy to have Julie with us. Thank you. We're hoping more of your friends and colleagues join us here as time permits, because we really wanted to have the opportunity to bring together a number of different disciplines so that we could start forming some more academic partnerships. That's big in our college strategic plan, to form more academic partnerships. And I think as we go through the morning with Dr. Mitchell, we'll see the importance of that in translational research also. So this workshop this morning is formatted in such a way that we're going to spend some time getting some baseline knowledge about translational research, and then have the time to talk a little bit, share a little bit, get some great ideas. And then I hope by the end of this academic year we'll have the opportunity to roll out a program where we can stipend some faculty to actually go to a foreign country. Okay, a different discipline. Okay. But it'll feel like that, so maybe we could have a nursing faculty go spend some time in the biology lab, and then have the biology researcher go out and spend some time in the field with the nursing clinician and scientist. And I think if we can carefully develop a couple of those opportunities for summer, it'll open everyone's eyes, because it truly is like going to a foreign country when you're in an area that's so outside of your area of expertise. So we hope to be able to roll that program out, this cross-cultural or cross-discipline program for this summer. All right, before I go on, I do want to take the opportunity to thank Terry and to thank Jerry. Where's Jerry? Wherever Jerry went. Oh, there you are. Oh, you're behind my screen. Truly, this was one of those kind of harebrained ideas that administrators have that other people carry out. And thank you guys very much. We're really excited. So I'm going to turn it over to Jerry, who will introduce Dr. Mitchell.
Thank you, Pam. And I just also wanted to say welcome. It's wonderful to have you here. For those of you who don't know me, I'm Jerry Bigby, and I am honored to serve as the Jody DeMeyer Endowed Chair here in the Boise State University School of Nursing. And I just wanted to say this is an exciting event, and it is supported in part by the Jody DeMeyer Endowment. So it's a good use of her legacy in our view. So before I introduce our preeminent guest, I was thinking, since we have a little extra time, that perhaps if you could go around and maybe just introduce yourself and identify yourself as a faculty or a student, and what school or department you're in. We'll be talking more about your research interests and focus later, so yeah, hold on to that thought. But at least let's find out who's here, and so start with Julie.
Tuttle,
Thank you, everyone. It's a great cross-section. And we hope that perhaps other faculty and students may be coming in as their schedules permit. Also spread the word that we are video recording this on Echo 360, and it will be on our website. So for those who weren't able to be here, we will be able to share that as well. So, at this point, it's my privilege to introduce Dr. Pam Mitchell. She is a preeminent nursing scholar and leader. And Dr. Mitchell is currently a professor and director of the Center of Health Sciences Interprofessional Education at the University of Washington School of Nursing. As a native Westerner, Dr. Mitchell received her bachelor's degree in nursing from the University of Washington, her master's from the University of California, San Francisco, and her doctorate from the University of Washington. She is a fellow and past president of the American Academy of Nursing, and her research interests are fascinating. They include the fundamental physiological factors influencing the responses of critically ill neurologic and neurosurgical patients to ordinary nursing care activities, clinical and translational trials aimed at improving recovery in chronic cardiocerebrovascular illness, and comparative effectiveness of healthcare delivery systems as they influence patient outcomes. A variety of fascinating areas. As a leader in translational science, she serves as the core director for research education and career development in the Institute for Translational Health Sciences at the University of Washington. Please join me in welcoming Dr. Mitchell.
Jerry tells me that I'm tethered to this place because of the video camera, so I'll try to. Yes, I really am tethered. There we go. There's the other piece of that. So I'm just delighted to be here, and I'm delighted to see such a broad group of folks. For those of you who are students, when I was in the bachelor's program at the University of Washington, our faculty decided that research was part of what nurses should be doing, and that was, as you can probably tell from the color of my hair, a while ago. And that was what really got me started in this trajectory. I just absolutely loved scientific clinical inquiry, and as you can tell from this broad range of things I do, I still haven't figured out what to do when I grow up, but I'm really having a good time at it. So what I want to do today is to set the stage for the workshop that you're having, get some definitions. There is no single definition of translational research, and it changes, it seems to be changing all the time, so that at the least you'll recognize that there are myriad definitions. We've been using a translational wheel to kind of guide how we're thinking about translational research in the Institute of Translational Health Sciences. And so I'm going to talk a fair amount about that and then illustrate that with some specific kinds of research questions and studies, including some from my own research. I hope that, well, I'm quite certain by the way this workshop's designed, that by the end of the morning you will have at least one possibility for some translational research collaborations in your area of interest, regardless whether you're at the very beginning level or whether you have been doing research for some period of time. And then lastly, identify some ways the Institute of Translational Health Sciences can be useful to you, and you'll see later as I talk about it. We're probably the only one of these, they're called Clinical Translational Science Awards in the United States, that has a deliberate focus on the region that includes Idaho. So we'll talk more about that later. And I did bring some propaganda with me, which of course I left in Terry's car, and we'll go get that at the break. So I think it's well worth remembering. Some of you will actually remember this, and for those of you who are younger, it's really worth noting that translational research was that term was first used in the literature by Jean Johnson, a PhD nursing scientist at, I think she was at Wisconsin then, on later at the University of Rochester in 1979. She wrote a paper called Translation to Practice. That was all about translating what we learn in basic research into practice. Of course, our colleagues in other disciplines don't read the nursing literature, so they don't know that, but you do. In the 80s, then this terminology morphed into research utilization, using the processes and the products of research, again, into practice. And there was a whole industry almost set up with that in nursing, but focused a lot on the synthetic reviews of research papers and deciding whether there was enough evidence to use in practice. And usually folks decided there wasn't enough evidence, and so it didn't ever get into practice. So we still had some more to do. Then in the 90s, this whole movement morphed into evidence-based practice, which should be a familiar term to everybody at this point. And then now in the 2000s and beyond, it's come back full circle to translational research. So in the beginning of the 2000s version of translational research, people were talking mostly about T1 and T2. T1 being the bench to bedside, the lab discoveries to clinical trials of interventions, usually drugs, but I think in nursing we've always thought a little more broadly than just drug development. And T2 was taking the fruits of clinical trials into everyday practice. Clinical trials being the preferred mechanism of really strict randomized controlled trials to look at the efficacy or the effect under the very best circumstances, and then moving that into everyday practice. And then folks who were trying to do this moving into everyday practice said, you know, that's just not broad enough, that there's more to it than that. So then the terminology began to be T1 being the phase of discovery, again, the bench to bedside, what the basic research is showing us that has applicability to clinical work. And for those of you in public health, you'll notice that bedside doesn't exactly describe what you're doing out in the community, and nursing is very much in the community. T2 then was the development of these ideas, moving the trials into practice, very much like what you see on the right side of the slide. But then T3 got added, which was really understanding what it takes to implement these discoveries into practice, or it's come to be called implementation science, the dissemination and implementation facilitators barriers. But then, I'll illustrate that. This was our early scheme at the University of Washington. We had a number of training programs for clinical research scientists at both the pre-doctoral level, people who were in their pre-licensure programs, and people who were in early career. And so we were visualizing kind of along the T1, T2, T3 continuum with the translation of discovery in this basic research, taking the basic science to human studies, thinking about behavioral biomedical studies, behavioral sciences, epidemiology, the public health sciences, and then the second, and then clinical epidemiology, which is the application of epidemiology to clinical issues, and then the development phase being to develop those basic ideas into actual trials in human beings, in the clinical trials. NIH has a very interesting definition of clinical. So there are whole grant things around clinical research. And clinical means anything that has to do with human beings or their tissues. So you don't even actually have to study real human beings so long as it's their tissues, which is relevant, actually, as we think about biomarkers and some of the things that we're doing now. So the T2 development was developing these studies, these clinical trials, the randomized controlled trials of an intervention, a therapeutic in any kind of area. And then T3, the implementation into actual clinical practice and making health decisions. So outcomes research, which is terminology that came about, those of you in health services understand that came about in the 90s, that we were going to look at the outcomes of clinical care and then trace back to try to find out what were the best interventions. The clinical epidemiology, health services research. And all of this ultimately aimed to better health. Notice this is a very linear picture, and I think we all were realizing as we were developing these things that it's not a linear process at all. And so one more typology began to add more to this, and then I'll show you another picture. So some folks in cancer, and particularly those who were working with genetics in the onset of cancer and in genetic predisposition to responses to treatment, said we really need to have at least 4 phases. So I would say this is the more recent one, but you'll still find people who do T1, T2, and some do T3, and actually we have 5 phases in the picture I'm going to show you in a minute. So again, the familiar part, the T1 being the discovery to the development of those interventions, the efficacy trials, refining these protocols so that they could be tested in everyday practice, which is often called effectiveness. All of that in the development. Then the T3 being that science of diffusion and implementation. Not only actually implementing these in everyday practice, but studying it, understanding why it works, why it doesn't work, why do some things get taken up, why does it take 22 years for other things to get into practice. And then finally adding the T4, the so what question. What impact does this have on human health? Does it change policy? So that really adds a whole nother dimension of things that one might do. So at the University of Washington, we have one of 55 clinical translational science awards that are given to research-intensive universities throughout the United States to try to speed this process up, to get this into discoveries, into practice, into impact faster. Throughout the United States. And so as we were grappling with these definitions and the processes and how are we going to work this out, we came up with our translational wheel. This was built actually on a model that some folks in our ethics and genetics group were working on with those 4 phases that Corey had talked about. And thinking about how they don't go in a line from right to left. They interlock like petals in a flower, and some of my colleagues much prefer petals in the flower, but we came up with this one as a group. This was team science in its best. We had a lot of arguments about it. So what we did was to take those phases, and then we added one. So we now have a 5-phase wheel. So T0 is really the problem identification. And that can occur related to any of those other phases. So in the T0 is identifying the problems. I think, yes, this will work. Okay. To identify those problems, what the opportunities are for research that's going to make a difference in human health. And that's at the center, not at the end. That's at the center, is the human health improvements. So from identifying the problems, one could move to the discovery phase, the identifying of those early trials to implement the idea to test out what the predecessors, the precursors are. Moving to T2, which is making an application to assess the efficacy, the impact of this intervention under the best possible circumstances. So that's classic randomized controlled trials usually. So again, and you'll notice that these little arrows link these. So it's not stepping here to stepping here, but maybe going back and forth between these until you get it right, till you understand why this application or this intervention works. Moving then into T3, the science of implementation, dissemination, diffusion, maybe developing guidelines. I'm really having trouble there. Developing guidelines. Then moving them into practice, trying to understand why they do or don't get taken up. Maybe you learn something along the way that sends you right back here into the discovery phase to understand better why some of these guidelines that we think have evidence aren't working, and is the evidence wrong. And then finally, at T4, evaluating this impact on real-world populations. So this gets us away. It does a couple of neat things in my view. I think most research that we do in nursing and in the human sciences is much broader than simply at the bedside. And so this gets us out of the bench to bedside language and gets us out into the community, into the real world where people live. It recognizes the back and forth and circular nature, and underlying this is implicit that no one discipline can do it all by themselves. It really says we have to have multiple disciplines, and we need to understand each other's languages in order to do this research. So I think another thing the Translational Wheel has done for us, we have 6 health sciences schools in the University of Washington: medicine, dentistry, nursing, pharmacy, social work, and public health. And then we have a myriad of other folks on the campus in engineering and bioengineering and biology and communications, and I mean, it can go on and on. But there are a lot of people from a lot of different professions and disciplines who are trying to work together on this knotty problem, and the language is a huge barrier. So this wheel has really helped us in unifying our language about this translational process so that we're using some similar language and not necessarily leaving others in the dust. Good example. When we were starting our Center for Interprofessional Education and Research, we were talking about taking students into the clinical arena. For nursing and social work, clinical is anywhere that people exist, because that is our clinical world. For our colleagues in medicine, it meant going into the hospital and into the clinic, the outpatient clinics. For the people in public health, they just threw their hands up and said, that has no meaning whatsoever. We don't talk about clinical, we just talk about health problems in the world. So we had to come to some similar language. This has done that for us as researchers, I think, to a large extent. So let me give you some specific examples. This is taken from that Curry paper, and at the end of this, the slides, there are some references which I imagine, Jerry, you can make available to people. So if we take this, then at T0, identifying those opportunities, one might ask, are there specific genetic mutations that are associated with breast cancer? And you probably all know the answer at this point, because there's been a lot of work done about those mutations. Then, at T1, having discovered BRCA, I've suddenly forgotten what that all stands for. Anyway, that's the mutation that is familial and is associated with breast cancer. So some observational studies determining whether there was an association with BRCA and breast cancer in families where that appeared, and then finding that there was the application in the phase, again, more observational studies at T2. So what's the positive predictive value? If you've got this genetic mutation, what is the likelihood that you will develop breast cancer? And upon that, people begin to make some decision-making in women in these families about whether they will do prophylactic breast amputation or not. And the research is not crystal clear, as a matter of fact. But that gets into the T4, the population health impact. What kind of decision-making do women and their physicians do based on this evidence that has been gathered at the T1, T2, T3, 4 phase? How many people are really at risk for this? So that kind of takes it, and it keeps going back and forth between, and again, these are not necessarily randomized trials. These were all observational studies looking at the associations. So I'll give you another example that's taken from the work of a group that I'm currently leading. We're very interested in reducing depression in people who have had stroke. There's about 30-some% of folks with stroke. That was that big, long, fancy cardiocerebrovascular disease. People who have had ischemic or other strokes, about a third on the average develop or have a new episode of depression. in the months following stroke. And it affects recovery, it affects rehabilitation. In some big population studies, there's even some suggestion that it's a risk factor for another stroke and or heart attack and death. So it's a big problem. So we've been involved in trying to, in a behavioral intervention that's used in concert with antidepressants to reduce the prevalence of depression in folks in a randomized trial. So the T0 part of that was a recognition that from an epidemiologic point of view, there is actually a fair amount of depression following both heart attacks and stroke. I first got interested in this in a study involving heart attacks, and it's pretty similar in strokes, in diabetes, and a whole bunch of chronic illnesses, as a matter of fact. But we decided to study stroke since we had neurologists and rehabilitation folks. And then we also got a geneticist involved with us kind of midway through this study, because of the recognition that there are certain polymorphisms or variations of a gene that helps us get serotonin into our cells, and serotonin is thought to be important in depressive symptoms. So we then got our geneticist involved as we went into the T1, the discovery phase of testing out an intervention that had been proven to be very helpful in people with dementia, with Alzheimer's disease, in reducing depression. That isn't to say that stroke is the same as Alzheimer's disease, but sometimes stroke does affect our cognitive abilities. And so that's what was appealing about this particular intervention to us, was that it could be used in people who have some cognitive issues. And so as we developed a classic randomized controlled trial in which people were either randomized to have some extra counseling during an 8-week period or seeing their regular provider, taking antidepressants for both. We came across Ruth Cohen, who was very interested in these variations in the serotonin transporter gene and its relation to both the incidence of depression and to how people might respond to this psychosocial treatment. So we got blood from everybody. Turns out you can do it just as easily with saliva, and that's what we're doing now. But we did get blood from everybody and tested for this gene. So we were doing some basic discovery about the associations of the genetic variation with depression in people who had had a stroke, some of whom were depressed, had depressive symptoms, and some of whom didn't. And then we further looked at whether this particular variation was predictive of people who responded best to the psychosocial treatment. And it was a very effective treatment. People did reduce their depression markedly. And the people who did the best were the people with this genetic variation of the two short alleles. It was a very small number of people. So we are now into the next phase, which is the comparative effectiveness trials, adding not only people with ischemic stroke from a blood clot, but people with the hemorrhagic forms of stroke, testing everybody. We got started late in this phase, so we had a relatively small number of people that we did the genetic testing on. We're now using saliva. It's way easier for people to spit and for us to store it than it was to get all the blood. And so we are comparing, again, usual care with antidepressant, the in-person delivery of this psychosocial intervention, which is essentially a counseling intervention, and the telephone delivery of it, all of which will help us understand both the best modes of delivery. I think we'll have enough people, we'll get a better handle on whether there really is a genetic marker of people who will respond best to it, all of which could lead us then to getting this into everyday practice in a cost-effective way, and ultimately perhaps influencing how stroke care gets paid for, so that you don't have to have X payment for treatment for depression and X payment for treatment for your rehab, but it all gets put together in a bundle, and the nurses in the comprehensive stroke centers could be calling people to see how they're doing the screening, and then moving this as a bundle of stroke care. Does that make sense? So we're not that far yet, by the way. We're only here. Yes? Oh yeah, no, yeah, I'd be happy to. And these papers tell something about it too. But it's actually a very it's a combination of cognitive behavioral therapy and problem solving, but it does not have the demands on a person of standard cognitive behavior therapy, which can be very long and prolonged. This is. It was originally 9 sessions over 8 weeks, and it initially got people to looking at pleasant events and what was still what had been pleasant in their lives before the stroke, what remains a pleasant thing, how they might change pleasant events in adapting to the disabilities of the stroke, and then talking about the interaction of behavior, environment, and depressive symptoms. We don't even use the word depression until the 5th session. So, in fact, we call this living well with stroke. Because we find, although we have a range of an age of people from mid-20s up to 90, most of the folks are in their 60s and 70s and are not real excited about being labeled depressed. And so we talk about feeling sad, feeling blue, finding it hard to deal with the after effects of stroke. So we start talking about depression and the symptoms and behaviors by about the 5th session. Then we move into problem solving around a problem that's important to them, and it often revolves around adaptation of, getting dressed, getting out of the house, managing time, those kinds of things, and then move into the very last, a kind of generalizing this to what you might do after the counseling sessions are over, the next time a difficult problem comes up. So our theory is that the antidepressants do improve mood. It takes a while, 6-8 weeks for many people. But what we're doing with the added counseling is giving people a toolkit for managing and coping with life stressors as they come along. And it appears that has been effective, because we didn't know if people would need a booster. But the people who responded very rapidly, were in remission by the end of the counseling time, and maintained that out to 2 years. So that's really exciting. Now we've shortened it to 6 weeks, and are trying to do it with the telephone. And so it remains to be seen whether that will work as well. The interventionists tell us it's hard to keep people on the telephone for an hour. And so the sessions tend to be shorter. They seem to get through the material, but they are shorter than they are with the in-person. So we'll see. But it's been an exciting time, and it was adapted almost word for word from the Alzheimer's one. We just changed your memory problems to your stroke. So it really was a very effective, and we hope that it will become something that could be. It certainly doesn't. Right now, we have psychosocial nurse practitioners who are delivering it, but it's well enough standardized that we could teach it to many people. And I think this is, with the many comprehensive stroke centers throughout the nation, I think this is something that the stroke nurses could learn to do if there were able to be a good payment mechanism that bundled it into the care that they're providing post-hospitalization. So that's looking on. That's what you want to do, is keep looking on to the future. And probably these studies are ones that you all will need to do, because I think I'll retire before we get there. So there's another way. I want to give another example that all of these are from the West, by the way. These others are from Utah. But another way in which we can use clinical data if it's well enough characterized in the patient's records to get at what those best interventions are. Susan Horn, who is in Utah, and has been working with groups in rehabilitation in what she calls sort of opening the black box of post-stroke rehabilitation, looking at the patient outcomes and the detailed clinical processes in the medical record. Now, clearly this requires it wouldn't have to be an electronic record, but it's a whole lot easier to do it with an electronic record. But it requires a clear understanding of what it is that the therapists, nurses, and everybody else are doing for the patients in rehab. And so what they have been able to do for all the professions except nursing, because our documentation is so crummy, I'm sorry to say, that it doesn't really tell the processes. You students are learning about the nursing process. What it is that nurses are doing that's contributing to the patient outcomes. The OTs and the PTs have very careful interventions noted down. There is a system that was developed at Iowa, the Nursing Intervention Classification, that very carefully tells all the nursing interventions people are doing, both physical, psychosocial, that you could use for this. And in fact, there have been some papers coming out of Iowa using this same method. But for the most part, most of our documentation, the nursing inputs are missing. But if they were there. So what this does is look at those things that I think are important to most of us as clinical professions, the patient's health status, their functional status, actually their psychosocial status is often, sometimes included in health status and sometimes not, but an important part of rehabilitation, as well as things that you get about cost, length of stay, how many times people saw different providers, and the process factors, and this is the care management strategies, what were the treatments and interventions, as well as medications. The place that we fall down in our documentation in nursing is the care management strategies. Now, I think in public health, Jerry and I had the opportunity to be at a conference in the fall in Chicago about public health nursing, and its specific inputs. I think there are, again, with the Omaha system and with some other systems of documenting community health, public health nursing, there would be an opportunity to do this kind of work. And then you have the patient factors. So all of these things that one size does not fit all. So which are most effective with which kinds of patients. But that's another neat way to do some research that is clinically based, that are really very well-designed observational studies that may lead us to be able to compare the comparative effectiveness of different interventions with patients. So my big message to you all is that I think that all of nursing research, and I'm using nursing research since this is a school of nursing, but research about human health responses and problems, which encompasses nursing research, can be situated in this translational wheel. It isn't, I don't think that we need to say that we only work at one or another of these nodes. And so I'd be interested in hearing from you where you think either the research that you are doing or something you're interested in would fit in this wheel. So I'll just throw that open to you all. And I guess I should, this microphone doesn't carry out there. I should repeat that, perhaps. Okay, so who's brave? Yes, Pam.
This is really interesting to me, and so I'm sitting here planning Jerry's life. That's all administrators do. But anyway, as you were giving your example about the work you're doing with stroke and depression, I thought about the large number of people in Idaho who are in rural areas who can't get access. Mm-hmm. It's impossible to stay somewhere for 8 weeks post-stroke.
Right.
And so the translation, I guess it would be in T4, of interventions that have been shown to be very, very effective in an urban setting and translating that into the rural setting.
Exactly. So testing these, that would probably be part of sort of T3, okay. Or comparative effectiveness, actually, which is now called patient-centered I don't remember. That the name has gotten changed for political reasons, but comparative effectiveness research is much easier. So that would be looking at comparing the effectiveness of an urban-centered intervention in the rural area. What adaptations would you make? And in our study, the telephone, that will be clearly, if that turns out to be as good as we think it will. We had a small pilot with 5 people who had been in the control arm of our original study. And so we tested this with those 5 people, and 4 of the 5 were still depressed, and they were not depressed when they finished the 6 sessions. But they were now 2 years post-stroke as opposed to right away. So the telephone would definitely be one thing to look at. So that has to do with access to health care. So that could have some T sort of in between T2, T3, T4. Yeah. So I think those are huge questions. And there at one time was a consortium of folks in the western region from Montana, Wyoming, I think Idaho through the Western Institute of Nursing that were looking at issues of rural nursing. And I don't know if that, Jerry, do you know if that's still alive?
I don't know that it's formal.
Yeah, Claire Ann Weinert from Montana State had a sort of formed that. So yeah, that's a great example. Something else. Yes?
All right, so I'm going to try and explain this because I'm not at level T01. But John and I, a couple of years ago, worked with the Latino population. So we conducted a baseline health assessment on originally 148 people. Since then, we've added about 80 more, and that data is being analyzed right now. And we did, some behavioral, collect some behavioral data, and then lab data, hemoglobin A1Cs, fasting glucose, lipid panels, and then we joined with kinesiology to do complete body composition testing. So instead of just a little height, weight, BMI formula, they actually brought their grad students and, measured. That's the part I didn't volunteer for today. So in the initial analysis, we found that some of the normal predictors that we would think would, because we were looking for diabetes risk, people with diabetes and the ones that didn't have it, and we found, and pipe in, because I get a little confused, some of the predictors just didn't match up with what we thought. So then we met with Julie in biology, because we were in her office, Pam's office. We were just kind of batting this around, and all of a sudden we started thinking maybe there is, a deeper biological reason for this, and so then we met with Julie to talk about some of those markers, and we just met last week, and I don't know where we are.
Oh, that's exciting. That's exciting. Yeah, I think. Oh, you're everywhere. No, actually, I think if I've gotten this right, you did basically an observational study, this basic assessment, and some things didn't match up, and so I think you're at the identification of problems, and then you're sort of headed towards some discovery work to see what are better markers or better predictors with these observational studies of people's health state. Is that a fair? Would you agree with that? So yeah, I think you're kind of in here, and until you know that, then it's not going to be very fruitful to be doing some intervention studies when you don't know what you're intervening on. So. I think that there's definitely been a trend in all sciences, not just in nursing science, that the only thing to do is an intervention study. But there's a lot of basic stuff that needs to happen before that. The other work that I'm known for has to do with increased intracranial pressure and the ways in which ordinary nursing care affects people's intracranial pressure and ultimately how their neurons fare, and does it affect their ultimate outcome. Well, we spent probably 15 years doing this basic discovery stuff to try to understand, first, did nursing care affect intracranial pressure in consistent ways, and no, it didn't. It was really highly individualized, and then get to some predictors for people that we would want to then change those interventions. So I think you're at the same place. You're trying to get a handle on how come this is all happening before you move to interventions.
You know, you're right, because so much of the intervention work that's being done is fairly standard. It's very, education. If people would just do this,
Yeah.
that I've been telling them. And then even the people that do the right thing, there was a big study over 2 years with type 2 diabetics, and the average weight at the time was 230, and they had this intensive program for 2 years. I think it was like hemoglobin A1Cs came down like 0.2. It was a large study, and so all this intervention didn't work because maybe we're treating the wrong thing.
Yeah. Yeah, or maybe it's effective for some subset of people. That's kind of where we're going with the genetic markers. It could be, in fact, both our geneticist is also a psychiatrist, so this is a wonderful blend because she has the clinical experience as well as the understanding of the genetic mechanisms, and it's based on some work that was done in psychology about sort of people's propensity to optimism and pessimism and seeing the glass half full, half empty, et cetera. It could be that the people who with the two short allele polymorphisms have a propensity to always see life as kind of on the half-empty side, and that our intervention gave them a set of skills to flip that around and learn to see the pleasant events, et cetera, et cetera. So if that was the case, then, and the other people, our people in the control group did get better over time, but it took them 2 years to get to the point where the other folks were at 8 weeks. So it could be that we don't need to throw this intervention at everybody. It could be that there's a subset of people who will benefit the most, and everybody else figures it out on their own. That would be both cost-effective and of everybody's time and effort. So, and it could be the same kind of thing. So there may be subsets, and I think that's where a lot of I think I heard somebody saying something about personalized medicine earlier. I think that's where some of that's going, is trying to identify the people who are most likely to get something or the people who are most likely to benefit from something. And that there's a whole lot of stuff that goes on here that then interacts with these trials. And of course, our standard randomized control trial, the more the better. So thousands is better than a few. And yet we wash out those differences in those large trials. So there's a kind of a back and forth. Any other? Yes?
Okay, I feel like my wheel is kind of spinning down the road. When I hold it still, I was a joint appointment with one of the regional hospitals based on a new clinic line. So it's very behavioristic at the time, and the evaluation over the term of the grant has been to look at the clinic itself. But as I gather this data, and it's all refugees and it's perinatal and pediatric, but as I gather this data and look at it, I'm finding out numerous other ways. And as I see the clinic itself evolve, there are numerous things that are brand new to what is going on. They've developed new roles, they've developed a different way for discharge teaching, because Boise is an open destination where people come from multiple languages. So I will finish up that, and I feel like we're going around, we're to the point where we're getting a lot of interest. We need to get this put into a toolkit. My problem is that I'm over there alone and I'm dying. But it's taken up numerous tentacles. And I'm looking at the future now, and this is where I feel like I'm going back around to T0. Because when I see the hematocrits, they're very low. And I want to know more because I've got several populations that we can compare, that we can look at where they came from. They are non-English speaking, and then look at their children. If we could get genetics with saliva, I'm very but to look at these extremely low hematocrits, which are going to follow me pregnant anyway, but to the point that they're doing having these blood transfusions. We've got that. We've got an innovative way to look at the mental health and PTSD that these people come from. I'm overloaded.
Yeah.
And
Well, and it sounds like, so you're talking about essentially evaluating a clinic model with a number of underserved populations, and in the process of that, you're identifying multiple problems. So indeed, it's almost taking this sort of real-world change in evaluation, which sets you into identifying numerous problems for research, and that gets to be really tricky. I was thinking about Susan Horn's, previous, let's try that. Yeah. This is a possibility, is to through, if depends on how well your records are kept, is identifying some problems through this record and the care management strategies and processes that are being used to identify a whole set of other research studies that could be looked at from that. No, you won't be able to do that all by yourself. Absolutely, we'll tell your dean. No, but I could see a whole program of research coming out of this program evaluation, in essence, that you're doing. And that's what I think is exciting about this wheel, is that it doesn't march, from the idea out to the traditional way of doing research in the standardized trial into then the implementation into guidelines. You can work backwards just as well, and then be able to identify those things. You've got graduate students now, I think, so you may be able to get some partners and some dissertations and theses and that kind of thing. So, okay, well, I'm going to go on. I've got a few more things I want to share with you, and then we'll have a good time for people to really do some good workshop-y work. And so out of, you actually, that was a nice segue, your discussion about working in this clinic and trying to evaluate it. And one of the issues as a clinician scientist, I've always been very interested in how can we partner with not only other scientists, but with people at the interface of people. I start to say at the bedside, because I do tend to work in hospitals, but how do we partner with practicing clinicians in any of these phases? And this particular diagram is taken from a paper that I like a lot from the Milbank Quarterly several years ago, in which they looked at all the models of how we diffuse, the diffusion of innovations, how we get evidence into practice. And I think as both as clinicians and as managers of these agencies and as scientists, I love this diagram, because the models basically range from you've got an innovation or a research-based thing you want to implement. It can range from letting it happen to helping it happen, to making it happen. And there's a different set of strategies that people do with that. I would say all of my work up until this stroke and depression one has been more of the notion of letting it happen. We put our papers out there, and you guys are supposed to do something about it. And so it's unpredictable, it's unprogrammed. Theoretically, if it catches on, it will emerge. And I think that's a lot of the reason why many research interventions don't make it into practice, is because there is no specific attempt to help that happen. It's just we did learn in PhD school that you are supposed to publish it, and then we sort of stopped there. Helping it happen then involves some relationship with people in the institutions where it's trying to happen. It gets negotiated, enabled, the classic diffusion model, that you'll have some early adopters and they'll start doing things. We had a little bit of that with the last ICP study we did, in which we had a really nice visual display of the intracranial pressure and cerebral perfusion pressure and the parameters that was supposed to be on, that was literally in the nurse's face. And the nurses really loved it, and they didn't like it when we brought in the control monitor that just said, please do not change settings. The program is working or something like that. So it actually did result in one of the companies that makes these monitors putting the CPP clearly on their monitor, but it was only this big. So that was kind of a little bit diffused, but not really taken into practice. The making it happen is a very deliberate attempt to get it in, and I think one of the best examples in my field is when TPA, the clot-busting drugs, were found to be extraordinarily helpful in reducing the impact of stroke if delivered within 3 hours. And so through the American Stroke Association and through institutions, this whole process of getting people into, what am I trying to say, the people that pick you up in the ambulance, the early responders, getting people to the hospital quickly, getting them evaluated quickly, getting them into the CT scan quickly, so that the, quote, door-to-needle time was less than 3 hours. That was a making it happen kind of innovation, and I can assure you it did not take 22 years for people to start using TPA. However, there is still a lot of resistance from emergency room physicians and a lot of places who are really worried about liability of doing that. So there's, you still see the curve of adoption. But that was dramatic. The other dramatic one was methylprednisolone in spinal cord injury now being given in the field by the early responders under protocols. Those are dramatic. Those didn't take 14 to 22 years. I think the ones that take a long time are the ones where we either do it at the let it happen or maybe have a little bit of help it happen. So clinicians and managers can be extremely important in that, and we see that in the stroke world with the huge number of stroke nurse coordinators who are now coming to a pre-symposium in the International Stroke Conference every year, who came to a session on guidelines, for heaven's sake. They packed the room because they're hungry to know how they can help make this happen. So I think that was exciting. Now this picture is messy, but it does much the same thing. I spend some of my time as a visiting professor at Duke University in North Carolina, and have been working with their Translational Nursing Institute, which is part of their CTSA, over the last couple of years. And they have a really neat model that was started by the associate director of the Heart Center, who is a nurse scientist, in which practicing nurses at the bedside identify clinical issues, problems for clinical inquiry that are important to them, and work through the whole process of designing small, local studies and getting them published and disseminated and used within the hospital. So this circle is very much like our translational wheel. Rob Califf, who's the head of the Duke Translational Medicine Institute, had developed this. And then what they've done in the DTNI is to get these touch points where the staff nurses find problems of interest. So it may be similar to the assessment that you all were doing with the Latino women in the community. They may be using their process improvement data to say, wow, we have way too many infections in these cardiac patients, and where are they coming from and what can we do about them? And then discovering that while they're changing the electrodes and stuff, the electrode boxes and the wires, there's just kind of a haphazard way of, do you clean them, don't you clean them, how do you clean them, who cleans them, etc. So taking that kind of very careful observational work and saying, this could be the source of the problem, then designing a very clever experiment in which one medical and surgical unit had a very specific way of cleaning the boxes and the electrode wires, and the others just did whatever they did, the usual care, and then noting the much a marked reduction in the it wasn't necessarily in the infections, but in the infectious agents that could be recovered from the boxes in the tube, because spend the rest of your life waiting for enough infections. But they clearly had the substrate. So kind of moving along, then they changed their protocols within the units. Anybody who was using EKGs, which was essentially a clinical practice guideline, and then continued monitoring to see if this still happened. Publications, those publications have gone out, and they've been reported at national meetings. So this is a very active way for clinicians to be involved in, I would call it research. Some people get snobby and say it's not research with a big R. But it is clinical inquiry, and it is a systematic inquiry, and it makes a difference in the care of patients in those hospitals. And lots of times it can be generalized, so that people are disseminating it and implementing it. So that's been very exciting. That is a very specific way in which this whole diffusion of innovation stuff can be enacted and actualized, and I'm not going to leave that. One that I love from one of our institutions, the Harborview Hospital is our safety net trauma hospital, and there's a lot of medical clinical research that goes on there. So there was a huge big study about hypothermia following cardiac arrest to try to preserve brain function and improve people's outcomes, and indeed it did. Well, the nurses on the units had the protocol that they were using, that was being used for the clinical trial, and felt that that was something that would be very useful to get out to other nurses when mild hypothermia was being instituted. So they published a paper with that protocol in RN, which is broadly distributed to practicing nurses throughout the world. So that came from a physician's clinical study, but had huge nursing impact. So it's clinician-based translation and publishing that research-based clinical protocol for others to use. So sharing those protocols, and I thought that was kind of cool. Then the last example that I want to show is we have something called the Seattle Nursing Research Consortium. You're all invited to come bring your staff nurse-based clinical studies to it next year. Once a year we have a conference that is sponsored by these 8 organizations in the Seattle-Puget Sound area, which is specifically dedicated to dissemination of staff nurse-based projects. So you could put your master's project in if you were a staff nurse while you were getting your master's degree. I can't put my research in because I'm not doing it as a staff nurse, but we serve as coaches to the staff in our hospitals as they develop their projects, and then this is often the first time that many of them have done any kind of presentation. So we have poster sessions and we have oral sessions, and people then go on to their professional organizations, and it takes some work to get them actually published, not because they're not publishable, but because people are really busy, and it's done, and so we do it. So these are ways that I find really exciting in this translational process of bringing the wheel back to the people who are taking care of patients and the clinical issues that they want. So the Duke Translational Nursing Institute is doing the same thing, quite a bit more organized than we are, as a matter of fact. But this knowledge development at the point of care is the node for their translation of bringing the ideas and the small-scale studies out to the rest of the organization and then to the world. So in the last few minutes, oh yes, question.
When you're taking the staff nurses' ideas, and I love the way that you're presenting it, how and with what hospital goes in their translational nursing committees, etc. How is this different from evidence-based practice committees that are more generally written? That MELOC is obviously every research book that you teach right now has research and EVP, but yet now we're calling it something different. There are similarities and there are some differences.
I would say that evidence-based practice is a component of the translational wheel. It's really taking the fruits of research and implementing them into guidelines and protocols, procedures in that particular agency. So it would be in that T3 component. Some people are studying how that happens. Now, what we're doing is taking a microcosm of T0, 1, 2, and 3 and putting it at the bedside, if you will, and it could be easily done in public health agencies as well. So that's now the evidence-based practice committees often spend a lot of time appraising the evidence, reading the studies, and what's worth implementing. The groups that work in the DTNI and in our consortium usually are more unit-based. They may be part of the practice councils. It just varies in hospitals. But they will take the burning clinical questions. They will go through some of those same phases. Somebody's got to review the literature and see if we know enough about this. Oftentimes the clinical specialist or one of us as the PhD scientist will help them with that, but oftentimes there's a master student on the unit who really wants to do that for a paper. But you do have to appraise the evidence, and if indeed there's enough out there that solves the problem, then you just test it in that unit and see if it works with that population. If there isn't enough, and that's often the case, then they design their own study, which may only produce local evidence, but they do design their own study. And we encourage people to use high-volume problems in high volume of patients, so it doesn't take you 16 years to learn this. Does that help answer that?
It does. I have a follow-up question. So after you have completed the EVP part, and I totally understand, and then you get to the part where, okay, you have implemented change, you've either got to do a QI or you've got to do original research. Is that where it branches off into translational research, or is that just finishing the cycle of EVP?
I would say that QI and process improvement blend into translational research. I'm really not ready to divide them as much as sometimes people do. And I think with the ethics committees and the IRBs expecting us to put these in, whether they're process improvement or not, if we're going to publish them, it blurs a whole lot more. So with the DEET, there was an example. There was process improvement data. Then there was the study, which did go to the IRB, and then they continued to monitor it, which is, again, process improvement. So those tend to blend together a lot. Not everybody will agree with that, and some IRBs just go nuts if you try to put all the process improvement in there. Okay, so lastly, then, this Institute of Translational Health Sciences, I think we can be helpful to you. So there are 55 of these. They're called Clinical Science Translational Awards that came out of the NIH. They're huge amounts of money that are being invested in trying to move research into practice more rapidly. So they are, as you can see, the middle of the U.S. is not as well represented as the coast and the Midwest, but ours, which is right here, and it's a consortium in Seattle of the University of Washington, the Fred Hutchinson Cancer Research Center, and Children's. Children's is no longer called Children's Hospital. Children's Medical Center or something like that. Anyway, and then some other research institutes is formally has developed outreach into the region, the Washington, Wyoming, yeah, I got it on here, Alaska, we better get the Alaska line down here, Montana and Idaho region, which originally started out as the way the medical school became a medical school for 5 states. So the regional outreach of our CTSA is not the medical school's whammy, but it's the wider region. And so our part of our mission is to provide some linkages and develop collaborations in the region. And it's not in the, we'll tell you what to do, but how can we work together, and where can the resources of the ITHS be helpful to you. So overall, these CTSAs intend to build a much stronger national clinical and translational research capability, largely through training at the individual ones, but also through the kinds of things we're talking about here. Provide training and career development for clinical and translational scientists, and enhancing the consortium-wide collaborations. Those are the areas I think we can do the most with. None of them have been around long enough to actually improve health, I don't think, at the community and national levels, but we're working on it. And encourage the acceleration of basic science discoveries to health applications, that shortening of that time. So ours is, the three core are Seattle Children's, Fred Hutchin, University of Washington, and then we're part of this national consortium, Group Health Research Institute, which has actually a national a physician-based clinical practice network, the VA Puget Sound, and actually there's we're doing some work with the Boise VA. I think in April there's going to be another conference. And the WAMI region, the American Indian Alaska Native Research Network, which is part of the network, I think, is in Idaho, but is a particular subset. The Northwest Association for Biomedical Research is a Seattle-based group that tries to work on community public understanding of science, and then the Benaroya Institute. So this is where we're trying to do more. So you've already actually, unbeknownst to many of you probably, have contacted us through the Research Navigator. Jerry contacted Beth Hacker and asked if there was somebody in nursing who could come and talk, and we managed to get this together. She's also available to help hitch people up with other investigators in the region, as is Lori Haskell. So there's some overlap with the regional folks, or get you to the right people. So you're going to have these slides for people if they want them? Okay, so actually, if you go to ITHS.org, then you can start navigating our website, and you can find resources, laboratory, person, all those kinds of things. You can get the navigator. So ITHS.org. If you just put ITHS, there's some other organizations, and I've forgotten. I think they have to do with chemists or something. But anyway, so then our education core is the other place where I think we could do some useful collaborations. There are a whole bunch of core competencies for research, primarily around the clinical, the T2, T3, that have been developed nationally that we're using to guide the offerings that we give through the Research Education Corps. We have two programs that are limited to the Seattle area that are the formal predoctoral and the early career awards, where people get stipends and some money to do their research. We may be able to open up the summer program in the predoctoral to the region, and we're talking about doing that in our competing continuation, which will start in 2012 if we get funded. And that would be kind of a neat time for people to come and work in Seattle, and I think we could figure out a way to do that with students of all ages, if you will. There may be, but I love what you're talking about doing in the summer, which would be exactly the same kind of thing.
Well, we have about 10 faculty in doctoral programs, in nursing doctoral programs right now.
Oh.
So that really is appealing.
Yeah, that would work very well. That would work very well. We have 12 spots in the summer program, but we offer sort of a core course, and that should be able to be done online by next summer. So there are some opportunities there in the summer program, and maybe even in the year-long one for people in doctoral programs. I'm not going to go over all these different skills, but these are the core areas that we try to get into one or another of the offerings that we have. So we have these two structured programs. Then we have what we're calling lifelong learning, and like everybody everywhere, people argue is that the best term? But it basically means everybody, not only investigators, but the research staff at whatever level that you are in the opportunity for essentially continuing education or for basic education. So we have, and many of these things are now being beamed live through Adobe Connect or archived on our website so they can be looked at later. One of the really fun ones that we've developed has been the interdisciplinary grand rounds, in which we take a hot topic each quarter. So in the winter, it was over-the-counter genetic testing. What are some of the issues about that? How accurate is it? What do you do with it? All those kinds of things. So we had people from law, from genetic scientists, ethics, and talking about that. We had another one when the before the autism study had been completely revealed as a fraud. What is the science behind this? The controversy about childhood vaccines and autism. When the breast cancer screening guidelines new ones came out, we had a panel that was talking about how would you do this? So this is really kind of at the, probably most of these are at that T4 level, and they're designed to be available and accessible both to the public and to people in the scientific community. We have a clinical research education series that's every month for research coordinators, investigators, about different topics, about nitty-gritties, about how do you get a new drug investigational, how do you go through that process, how do you go through the IRB, what are some of the ethical issues involved in enrolling children. So there are a whole lot of topics, and it's sort of designed as a 2-year series. All of those are now archived. And then career development series that's around nitty-gritties of writing grants, how do you make a poster, what do you do about issues of authorship, those kinds of things. So all of these, the ITHS.org/training/online is the way to get at our archive. It looks clunkier than heck at the moment. It lists the names of things, but you can find what you're interested in, and then you do have to register, and that's good because then we know about you too, and where our audience comes from. But you don't have to pay anything, and it's a quick registration, and then it takes you to the video. Some of these have been done by UW-TV and put on their that reaches, I don't know, 33 million people or something like that through both the ones that they do on UW-TV, which is on cable television, as well as the online ones. So there are lots of those kinds of things that are worth browsing. We also have something that we call boot camp. It's really the basic research. It's a week-long institute, heavy on the basic clinical epidemiology, biostats, clinical trials, how they're conducted, a few things on some of the resource technology, which have not been as popular. Most of the folks that come to the boot camp are sort of at the beginning phase of clinical research, and they want the basics. But we have had these available, and those too are archived online. And in fact, people have told us that they use this in their courses for people from time to time. And then we'll be alternating that every other year with a specialized topic institute. So this next fall, we're going to do an Institute for Comparative Effectiveness training. I gather, I just learned yesterday on my way out that apparently this date is not, it may be the week before it, but it'll be in September. It'll be a week long, and it will have experts in all phases of comparative effectiveness research. So that is another possibility, and we're going to continue to make these available online as well as in person in order to get a wider reach. So I think so. And you can join ITHS. You just go to iths.org/membership. You can just go to iths.org, and there's a thing that says join. And you do this electronically, and you can become a member. Doesn't cost you anything. If you're in the local area, you may get called on for mentorship and things like that more often. There is grant funding available to folks in the region who are ITHS members. Once a year, small grant funding. Right now, we rarely charge for anything. We're probably going to have to over time as funding gets tight and stuff, but ITH members will have reduced rates and preferred registration when registration is tight. People who use the Clinical Research Center get reduced rates, but I don't think that's going to be feasible from here to Seattle. So, and it is open. It is not for the scientists only. It's for everybody who's part of the research team. So I do have some material. Beth Hacker would not let me leave without bringing it, and of course I left it in the car. But I'll bring it in after the break if any of you want to take a look at that. And I think that's it. I have some references here that would be easier to get to you on paper than up there. So, and you have one of them actually in your packet from Nancy Woods and Diane Madgery. So I've probably taken most of the time, right? Yeah. Yes.
Thank you.
Okay, so thank you.
And stay right up there because now it's question time.
Oh, okay.
We've had some good questions already, but how about some more burning questions for Dr. Jones?
Yes.
Actually, I'm just trying to figure out the organization with the CTSA
Yeah.
and your organization, and is this a branch of the entrepreneurial research or?
It is. The CTSA is a consortium of all of these places throughout the United States. We are one of those. And so we link with the national one. But we are ITHS. Everybody names them something different, so you'll be confused about that. We're the one who would be available to be of assistance to you. Yeah.
Do you know if the CTSA program at NIH, is it growing? Is it projected to grow over the next?
Yeah, good question. Is it projected to grow? It is projected to go to 60 institutions. So there are, I think then this year is the last year that new institutions will be able to join. And, with all the proposed cuts at NIH, I don't know what that's going to do to the number of them. But, yeah, it's proposed to be at a steady state of 60. It now is at 55. I hope so. After the amount of time and energy we've all put into it. Dr. Collins, the new head of NIH, has proposed a more drug development focus for translational research and has gotten huge amounts of pushback from Congress and from actually the CTSA themselves, so we'll see how that plays out. I suspect there may be more emphasis on that, but I think that people have really found this a home for community-based research and the outreach that just hasn't been available in other venues, and there's been a lot of pushback to making it strictly drug and device related. There's a question in the back.
Yeah, I apologize for coming in late. I represent the Center for the Study of Aging here at the university.
Uh-huh.
Shifting individuals out of long-term care
Yeah.
back into the community. And we have done some initial research around cost savings of shifting with those sorts of proposals, and wondering if are there opportunities in the translational research in helping in the policy arena, education, really being able to support some substantial studies in documenting outcomes of policy.
Of the policy, yeah, that definitely would be, systems research in that T4 arena. Now, how much money is being put into that is a whole other question. But I think one of the definitions in comparative effectiveness research, which was a big push, and a whole lot of money got put into that recently, is comparing the systems of care as well as individual treatments. So that is an arena where there might be definitely money available. I don't know how much ARCA's putting into that, but yes, I would say that is definitely a part of translational research, is doing just what you're doing, evaluating the impact of these changes in policy, or providing the data that might lead to a shift in policy. Public health systems research is another area that's just beginning to grow, in which I think that's research that will should affect policy. You know, there's always the politics about policy, but yeah. So
are there individuals that we should establish connections with?
well, our CTSA at the ITHS, the Community Outreach Court. What does that stand for? Community Outreach and Research. I don't know what the T is, but anyway, that it's one of our many cores. They are particularly, I think, have more focus on the community-based participatory research and the outreach, and particularly with the Native American, Alaska Native tribes. Whether or not I don't think any of them view themselves as policy researchers at this point, but their work definitely influences policy. So probably, if you went to iths.org, you might click on CORT, on the cores, and talk with some of those folks. Or the other, Lori Haskell is she's in Coeur d'Alene, and she's the person who is kind of the nub for the regional outreach work. You might ask Lori if there's some people that specifically that you should connect with. I don't, and actually, although there's an Institute on Aging at the University of Washington, they're not doing any of this kind of work that I know of at the moment. So it's a many-headed hydra, but it doesn't encompass everything about the University of Washington. So but it is tending to make connections and bringing people together, and I think that's a real value, so that that we're not reinventing the wheel in each of our areas. Jerry.
I have a global question in terms of what do you think the movement towards translational research means in terms of the future of nursing research? Is this the dawning of a new era when nursing research will blossom and bloom, when we'll have interdisciplinary collaboration and fully participate as full partners? What do you think?
Well, I remind you of that first slide that I showed, where in 1979, I was on this side of the slide, Gene Johnson talked about translation into practice. I think that translation, the common language in translation, does give us an opportunity in nursing research to communicate using the same language, or communicate with folks in other disciplines and other professions who are doing research. I think that there's a lot of overlap of research that is of interest to nursing scientists and others, particularly in the behavioral area, but also in the biologic. There's a lot of, my department is called biobehavioral nursing, and that's because we like to combine bio and behavioral, and so biomarkers and things are really of great interest. So I think it has the possibility for nursing to have a greater entree into the wider scientific community, but only if we take it, and only if we're able to articulate what our research is and what impact this is having on human health. So that has been, I think, one of the promises of this the CTSA, because it's deliberately the whole movement sought to include many disciplines. But language is language. I have a close colleague who is a physician scientist, and to him, multidisciplinary means that he has urologists and pediatricians and cardiologists working together. And So there we are. So it's up to us to articulate what we're bringing to the table. And you all are articulating wonderful research that I think can well bring it to the table. Within the CTSA consortium, we have started at the Nurse Scientist Special Interest Group, which brings together the nurse scientists from each of these 55, well, not all of them have nursing in them, but from about 50 of the 55 CTSAs. And so we have telephone meetings and then some face-to-face meetings, and we've developed a symposium for a gathering in April of the early career development people, and are using examples of research that's led by nurse scientists with multiple disciplines in a variety of areas. So those are the kinds of things that we're trying to do. Does that answer? Okay.
One of the problems that I keep encountering, and from what I hear others encounter here, and that is that Boise is really had a fun decade of really growing and becoming nationally and gathering national attention. But one of the problems that we have directly in nursing is getting the connections with people that can help us get the funding. And I know that we're trying, et cetera, and my thought is now that you're here, I'd just love to connect with us. And can you help us? Because we have such a diversity of what we're interested in. Is it a possibility that to work with you, you could put us in touch with someone who has similar ideas that we can begin to share? We need these, obviously interdisciplinary, but we need multidisciplinary and interstate connections.
Yeah, no, I think that would be a great opportunity. That might be the kind of thing where building on what you're doing today, in which you're going to get together and get some of your ideas going, is then creating some workshops for grant writing, essentially, and that actually can be done. It can be done long distance in a way. This is what our structured training programs do with the folks who are early faculty across schools that are getting stipends and some nice money. But they come together in the works in progress sessions, and they help each other, and the faculty help them in developing their grant proposals. Something like that could be done on a more long distance basis in the lifelong learning. I think that's the kind of thing we could probably put together on a what am I trying to say? Boutique basis. So that rather than just saying anybody who wants to come, we say, okay, for Boise State, and we're going to devote a day to this. And you have distance capability. I mean, everybody does these days. So you can do it by distance, or it could be done again in actually having live people working with each other. Yeah, and I think those are the kinds of things we've talked about doing in our continuing in the career development component of our competing renewal. So you've just given me a splendid idea.
Well, Pam, the other thing that I think we need is a lot of opportunity to be scientists on projects that have real scientists leading them. We're new. We're very
that have experienced scientists leading them. You're new scientists.
Yes. Yeah. We're very new.
Yeah.
And we're trying to find our way. And we have some great examples in this room of nurse scientists who are doing it on their own without mentoring. And that just listening to you is really inspiring, I think. Well, it is for me. And to be able to hook up with researchers from the University of Washington who, like your stroke study, okay, could we be an arm of your stroke study? Because we would learn by being an arm of a study that you have, those kind of things I think would be very helpful for us too, if we're talking about our dream boutique.
Yeah. No, that they're the women's health, the Center for Women's Health Research was, I think, 15 years a center from NINR, and they had affiliations with the University of Hawaii and West Virginia. Don't ask me how that happened, but anyway. And so that's exactly the kind of thing that they would do. They had small grants, and those would be available, and then people could work together on those. I think there are ways that we could do that, both individually, because the ITHS doesn't. At the moment, it is a science enabler. It is funding infrastructure to help bring people together. It's not funding a lot of science itself. But it does do some of these small grants and some of the regional grants. And there's also a scholars program, and that would be something else that your folks would be eligible for, and I think there was a competition last year. So we could do that. We could also try to do some matchmaking well beyond the ITHS grants.
We could offer a small stipend to a faculty here who could go purchase somebody from, an experienced scientist from the University of Washington to join and come and help guide and mentor. It's the mentoring.
It's the mentoring, exactly, and also you talked about people going and immersing themselves in another world for a period of time in the summer. We could do some similar things like that. We've got postdocs who are part of our research team who come to our team meetings and hang out with the interventionists and that kind of thing. So yeah, those are lots of those opportunities. Did somebody have a?
You might have answered my question. I was going to ask you some of the ideas that you've been hearing in this room today. Do you think that the small grants opportunity that ITHS is offering is appropriate? Would you suggest people pursue that?
They might be. Yeah, they might be. The next round won't be until the fall, probably. But they're like $10,000, which is not a huge amount of money, but it is enough to get some pilot stuff started or a collaboration started. Then there also are some where you can, as you said, kind of purchase some resources and maybe bring somebody. But I think you were also talking about having people really sit down and work through the grants processes with you. Now, you've got a grants. I mean, we have a grants coordinator back here, so it's not that you don't have some infrastructure for that. But yeah, it's we don't do a lot in nursing with multi-site studies. Actually, having been part of big national one, I think I understand why, because it's really quite amazing process. But there is more that we could do, and there are a lot of. We've talked about that in our Seattle Nursing Research Consortium of doing even some multi-site studies within the city and the consortium, and there might be ways to develop that kind of thing here as well, because it's you often don't get enough people in any one site to say more than about any one site. The biomarker connections are hot these days, and you just came back from a conference. Yeah.
Okay, let's go. And as we network, there's going to be interests that we have that are going to dovetail with each other. For example, my area is pain-related disability, and there may be areas with Kathy's clinics where that may fit, even though we're definitely not
Right.
match on everything.
Right.
And there may be areas where biomarkers might be very effective for looking at pain-related disability, especially with certain kinds of pain, and we might dovetail there. So I can see where just even amongst this room, and then if we could branch out, we could form some very powerful partnerships.
Absolutely. And you as a smaller institution, you're eligible for these R15 grants from National Institute of Nursing Research, which are developmental mentoring grants. And I think I think the notion of reaching out for mentorship and a sort of advisorship from more experienced people is a perfect one, and it's fun, for everybody. Yes.
Just to build on that, I think one of the strengths of the R15 mechanism is that it also encourages undergraduate involvement in research. And I think that's another thing that we really do well here and are very committed to. And do you see that other folks who are active in translational research efforts are really focusing on undergraduate research as a component?
Not as heavily, yeah. The president before last at the University of Washington really wanted to get undergraduates involved in research with senior faculty and had a big push for that. And that's continued, but it's not, I think it's very easy for more senior investigators to sort of hire the help and forget to get undergraduates involved, both as helping collect data, but also as part of the design and their own research projects. So yeah, I think it's super. It's exactly what you need to do. I was. I didn't even remember at the time that one of our faculty came. She and I were talking, and she said, "I don't know if you remember that I was one of the undergraduate students collecting data on your first intracranial pressure project." Well, no, I hadn't remembered that. I know we had lots, because we sat at bedsides for 24 hours and watched machines, but I had not remembered the specific people, and that got her started in her research career. So, yeah. No, I think that would be really a very fine thing that you could be doing.
Other questions?
Well,
Okay.
thank you all for coming. A great discussion.
And we have a little gift.
Oh.
2-minute gift.
Oh.
From Bronco Nation.
Oh, lovely,
Yes,
lovely.
thank you
Even if
so
you did
much.
beat us very badly in football.
We all have our strengths.
Blue is my favorite color, as a matter of fact.
Yeah, orange with- So thank you. And
Thank you.
As you can see from our schedule, we're a little bit ahead of schedule, which is always nice. We're going to let's take a 15, 20-minute break and come back. And the plan is to bring together some small groups to really start doing some brainstorming together about, wow, I'm inspired now. This is where I think we could go, and maybe partner with folks that you haven't known before, or that might have some similar ideas or perspectives. I think would be ideal. So this room is not ideal for small groups, but I think we can make it work. And kind of knowing a little bit about where your focuses are. If we had a small group that perhaps looked at diabetes, endocrine-related questions, that might be a small group. We also, I think, have a little cluster of folks who are talking about population-oriented, community-based disparities, that group. We might have a group that's talking about pain, rehabilitation, those kinds of things. Am I clustering them at all right, or what do you think?
It might be interesting, since we have Julie with us today, for anybody that may not exactly know how their research could tie into biomarkers, to have a little time where maybe we can learn some of each other's language.
That's true.
Would that put you too much on the spot, or?
No, I am happy. I'll try to answer any questions I can. But I do think that we could come up with something for the summer if we were focused. I think that, I'm thinking of saliva, and I'm thinking maybe we could try a few things that see what can we detect in saliva and what is the process that one goes through when they're trying to see what's there and then evaluate, see what is a useful marker for whether it's a state of stress or a specific disease.
Can I ask a question of somebody who knows St. Luke's better? There was a thing on TV yesterday, I think it was yesterday, but they are opening a brand new lab. I think it's the old Micron building out there. Yeah. Are they going to do genetic testing? I thought they were.
It looked to me like looked like a clean room. I don't know. The only thing I had heard was that they were expanding their pathology department tremendously, and they were going into what they were calling molecular. What did I say? I meant pathology.
Pathology.
Okay. That they were really branching out into the molecular pathology, and so that would include all sorts of great things.
That's involving one state.
Yeah. Okay. It looked so exciting. The labs were beautiful.
Yeah.
Well, it sounds like perhaps we might, when we come back, it might make some sense to spend more time together and maybe pick Julie's brain a little bit as our resident biologist here. Talk maybe a little bit more about biomarkers and those kinds of things. And, you know, if we feel the need to break into small groups, we can certainly do that. We have until noon. And so let's take a break, and I'll see you back at about 10 to 11. How's that? So if you want to take your seats, we're having way too much fun.
That's a good sign.
That's a very good sign.
Sorry.
That's okay. It takes a while. That's okay. Okay, well, again, this is a brainstorming time, so we can do this any way we like, but I think one thing that might be fun is for those of you who have not met Dr. Julie Oxford from the Department of Biology. She's a wonderful resource for us, and I think our link to basic science. So I've asked Julie to kind of come up and talk a little bit about herself and what she does, and also some of her colleagues over in the basic science disciplines, and what some of those possible links could be to get some of our thinking going about possible collaborations. So, Julie.
Okay, so, yeah, how far away does this have to? If I just put it right
You put it
here?
on, yeah.
Okay.
And you have to kind of stay in this area.
Okay, I won't move. Well, I'm really happy to share any information I have about your colleagues a mile away on the other side of campus. Maybe it's less than a mile. But I got here, I came to Boise State in the year 2000, and I came from Oregon Health Sciences University. And there I worked at Shriners Hospital for children, and I also spent some time at the dental school. And while I was there, I also went away and took a couple years and went over to Colorado State University and worked with a group of equine orthopedic surgeons. And that's as close as I've been really to clinical research. But so that's in a nutshell. That's where I've been. So my research funding has come from the Arthritis Foundation, and then also from the National Institutes of Arthritis and Musculoskeletal. Let's see, NIAMS. Yeah, okay. And I think in skin diseases, they lump all those together at NIH. And then I also helped direct the statewide INBRE program, which is the NIH's program for IDEA states. And I know those are all acronyms, which is just really embarrassing. But the IDEA states are the states that receive a smaller proportion of NIH funding than most of the other states. And I think there are about 23 IDEA states. And IDEA stands for Institutional Development Awards. And then INBRE stands for IDEA Network for Biomedical Research Excellence. And I know that INBRE program in our state is really committed to working very closely with the Institute for Translational Health Sciences. So it's really, really exciting. So it's part of the biomedical research program's mission within the state of Idaho to increase translational research. So it's really exciting to me. I think that one big challenge that I find when I think about translational research is, where do I fit into your wheel? And I think maybe I fit into T0 and T1, but then I think the other point that was brought up by somebody here was that it's really important to articulate and communicate where your work fits in and how your work, basic research, impacts human health. And I find that to be a big challenge, and I wonder if we ought to spend some more of our energy trying to help people learn the language, kind of. But anyway, so I just got back from a meeting on personalized medicine, and it was really exciting. It was a meeting focused on research cores, so shared research instrumentation, and how those cores address translational medicine. And we have a core, a molecular core here at Boise State called the Biomolecular Research Center. And the Biomolecular Research Center has been recognized by the state board since 2004, and it was started by the NIH funding from IMBRE. And but we don't actually exist anywhere. We're a distributed center, but we're doing okay. The university promises us space in the near future once, all the dominoes, everyone's growing. It's a really exciting time at Boise State. So sometime we'll get a little bit of storefront or create a cohesive unit, but there's a lot we can do in the meantime. And the biomarkers, my idea for biomarkers, something we might be able to do this summer would be to let people see what detection of a molecule would be, how you would do that from a saliva sample, or how one would do that from a blood sample. And I think that could open the door to lots of more complicated, more complex things. It would be a learning experience on our side of the side of the whatever equation, and then I think that it would be a learning experience for the people that are collecting the samples, actually. So I think it would be really educational for everybody and really fun too. I think through that interaction we probably could discover where our real overlaps are and where our potential is for these collaborative grants that we're going to write that get submitted to Institute for Translational Health Sciences. So my lab, I'll tell you about the research that I can think of that in the Department of Biology and the Department of Chemistry. And so my lab, again, it's focused on musculoskeletal tissues, and the questions we ask when we look for medical relevance for our work, we look to arthritis and osteoporosis, and some rare diseases like Stickler syndrome and Marshall syndrome and Ehlers-Danlos syndrome. And those all come along with a whole set of different conditions that affect the eyes and the ears and heart. And I teach developmental biology, so my research also addresses embryonic development. And so diagnostics or diagnosis, early diagnosis on any of the diseases I'm very interested in. So I feel like our lab could contribute to diagnosis through biomarkers. And through collaboration with Cheryl Jorsick in the biology department, our lab has even been able to ask questions about cancer. And maybe the molecules we've been looking at in the past for other reasons, maybe they have value in cancer diagnosis. So that's really exciting to think that we might be able to impact cancer as well. So Cheryl is very committed to cancer research. You probably have heard about her and are a little bit familiar with her work. And then Dr. Kristen Mitchell is relatively new here at Boise State, but she is just really going full force in research. Her expertise is in toxicology, and she focuses on liver and liver regeneration. And so there's lots of neat questions you can ask in that realm. Juliet Tinker focuses on vaccine development, and her field, what she's trying to do that is really unique in my mind and novel is develop vaccines that are based on cholera toxin. And the cholera toxin has been taken apart and is used as a vehicle to get things inside the cell. And so she's exploring all sorts of interesting ideas around that. But she also is interested in diagnosis. She works on all sorts of other diseases too. So she is looking at West Nile virus and oh gosh, I'm going to forget some of them. So like five different diseases she's looking at. So so she's interested in immunization, vaccine development at the molecular level. And Ken Cornell is a microbiologist that's located in the Department of Chemistry and Biochemistry. And he is also interested in West Nile virus. He's interested in interested in organisms that form biofilms on like medical devices and how those organisms might change and become more pathogenic if they have this other states. And he's very focused at the molecular level. Let's see, who else? Troy Rohn. Troy Rohn studies Alzheimer's disease, and he is committed to finding he finds molecular markers and then develops antibodies against those markers and then tests those on brain samples. He has a very strong collaboration with UC Irvine, and he has found some very, very useful markers. And then he's been focused on the marker side of things, but he also recognizes that if you find a biomarker that has some sort of distinguishing value, you might be able to use that as a way to develop a preventive treatment, perhaps. So that's the real exciting thing to think about. And so he's interested in doing that too. Let me think. I'd go around the hallway here and see. So Denise Winget, she has a background in immunology and is very interested in questions about asthma, and has recently become interested in looking at a way to specifically kill cancer cells using zinc nanoparticles. So that's pretty cool. And I think, she's interested in the molecules that sit on the surface of certain kinds of cells of the immune system too, and seeing how useful they are for modulating the immune system. Let's see, who did I forget? I'm sure I've forgotten someone. There's a group over I'm going to jump over here. There's a group over in engineering that is very collaborative. It's Bill Knowlton, Bernie Yerke, and Will Hughes. And they are doing something they call DNA origami. And they are creating a platform to detect very small, very, very low levels of certain molecules in blood samples. So they are right now focused on asking the question if microRNAs can be detected in blood samples in a way that would be diagnostic for certain cancers. So, but what they're really doing is creating this platform for a sensor, a very sensitive detection system that could be used for any of the types of things that we're talking about. And there are some other engineers that are working on sensor type things too that will detect low levels of our biomarkers that need to be tested. So I'm sure I've forgotten someone. Henry Charlier. Henry is an enzymologist in chemistry, and he is looking at he's really focused on the side effects of chemo drugs. I'm missing my term there, but he is trying to lessen the severity of the secondary side effects, especially the cardiotoxicity of anthracyclines. And he has some really exciting findings. So he's in the process of patenting things. Let me see. I'm sure I've forgotten someone, but just a really superficial overview. But the idea of looking for biomarkers on some of these projects is really exciting, and I think that you know, on our side of campus, we are trying to build up research infrastructure and really focus at the molecular level, and both trying to detect low levels of proteins, but then also trying to detect certain messenger RNAs. And either one of those methods of detection could be explored during a summer collaborative project, I think. The companies that we purchase things from are more and more setting things up in an array, so you can ask essentially 96 questions at once, or maybe ask the same question 96 times so you could get, you know, really high confidence. But we can use those. I think that would be a great place to start. I think it would be really exciting. I think it's doable. I know everybody's busy, but I think that would be a place to start that would be doable. So we could confirm existing markers, but then we could take it one step further and discover new ones. I think that discovery step would be really exciting for people in biochemistry and chemistry and biology to be contributing to that next diagnostic. Yes?
I kind of have some ideas on what I think I might be looking for, but they're still kind of out there a little bit. In my area is limb loss, and when you look at what causes limb loss, there's definitely, along with the medical causes, is going to be a degree of inflammation to the vascular system, and they can also cause a lot of other problems that typically go along with it. And would there be some markers specific for inflammation, and maybe look at different populations, maybe diabetics with limb loss, diabetics that haven't?
So I think that's a great idea, and I think inflammation is one of those areas that seems to impact every single disease that we look at. And so markers for inflammation are, Cheryl Dorsick is really interested in those, Kristen Mitchell is, I am, Julie Tinker is, because they're impacting every single one of these different diseases. And there are some products that are available commercially right now that there are sort of libraries of molecules that are associated with an inflammatory response, and that might be a place to start. Just do a kind of a general screen and see what is either elevated or depressed in a sample of interest compared to a normal control.
And just ballpark, but if, say, it was a small pilot with maybe 5 in each group or something like that, what would the cost be for the benchtop research alone?
I don't know, but I think it's affordable. I think when we're talking about these small-scale projects, I think that they would definitely fit within one of the ITHS grants, but I also think that we've got some seed money here on campus to make that happen. I think it's definitely less than $10,000, and it's probably, I think it's less than that. So, and we have the instrumentation we've tried to acquire and establish the expertise for here on campus are things like mass spectrometers that could detect low levels of protein and identify the specific protein. So we have those, and then polymerase chain reaction, PCR thermocyclers that can detect low levels of specific messenger RNAs that could tell you what the cells are expressing, what they're making, and how those levels are changing. And then there are a whole lot of antibody-based diagnostic reagents that we could do. So.
You're glowing.
Right. Anyway.
I have a question in terms of
Yes.
We have a perspective on health and wellness and treatment. I mean, are they looking for clinical partners like us? Because we certainly would get a lot out of partnering with them, but would you see it as a two-way street?
I think so. I mean, I would hope so. I think it would be, and then it would take some time and effort to maybe match people, I guess, or maybe it's a grassroots. I don't know. Maybe it's a networking thing, and then people find each other. And I'm not exactly sure what the mechanism would be, but I do believe that there are people that would love to be involved in the development of a diagnostic tool or discovery of a biomarker. So the instruments that we have are set up as shared research cores, shared research instrumentation. So they're available to anyone that wants to use them. And then we're trying very hard to make sure that the expertise and technical support is there to help people use it. So that includes sample processing and experimental structure, and we're very small too, though, and so we're just trying to figure out what we do need to put in place. And so we look to University of Washington to see what they do, because they've been doing this longer than we have.
You know, the other reach out that we've seen is, for example, with Troy, he's really interested in getting involved in the policy. And so he's working with us on a statewide plan for Alzheimer's disease and other dementia. So we're able to provide a link to him beyond the laboratory that we have in public health that it's difficult to develop within the basic science world. So I would encourage us to think broadly about what we as a college brings for basic science researchers. That we may think, everybody's got that, but
you know, and the other example is those professors in biology or chemistry that have expanded the courses that they teach to include a service learning component. They really want to be involved in something that means something to the community, and they see the value in teaching their students that it's important to be involved. And so Cheryl does that with her CAMS Biology of Cancer class, and her students go and talk to family members of cancer patients. And Kristen Mitchell, who teaches, I think she teaches human physiology, and she sends her service learning students to the YMCA, as well as some other places, to talk about physiology and other things like that. So there is a lot of interest in that. It's one of the reasons why people come to Boise State, because they want this balanced, well-rounded, this is, you know, research and, you know, how it impacts life, I think. So, anyway.
You know, the faculty connections group that is meeting right now, as we are sitting here, has been really helpful to us to connect with biology and chemistry. And you know, I think this semester we're going to visit Henry's class and talk about what does research look like with people versus bench students, and then we're thinking of a way that we can take the children of our research participants who are all Latino, bring them to Henry's lab and say, this is college is achievable, and these are maybe some of the really fun things that you can do. You know, so I think making those connections in an informal way, it's just been really helpful.
Yeah, I agree.
You know, one of the things that the Research Resources Group developed at the UW that could be replicated with what you're talking about. They have a metabolomics users group, and so it's people in the labs who are looking at metabolic molecules, various things, and people who are trying to apply that. And so they have both technical, you know, how do you solve this kind of problem, and a lecture from somebody about some particular approach to looking at metabolomics. That might be a similar, you know, a biomarkers users group.
That's a great idea.
Brings people together so that the languages get understood and what people are meaning by different biomarkers. And that's something you could do locally very easily.
That is a good idea. I like that.
To speak for one of our other colleagues who couldn't be here today, one of our newer faculty is a national leader in breastfeeding and lactation. And you know, I think we think, well, what would that have to do with anything? But you know, I was involved in a study at one point where we partnered with a basic science group who were testing breast milk in smoking mothers, and how much codeine is that is getting through the breast milk. It was cutting edge stuff. It was great stuff. And you know, again, we have the opportunity. You know, you have to have some ins to get breast milk. You know, those kind of ins. You know, especially Dr. Grassley, our colleague. But I think, you know, thinking in that way, very important research. But that partnership would be critical.
Right. That would be good. Well, and so the meeting I went to just recently, I went to a few sessions that had to do with, you know, how sensitive is the detection for certain biomarkers in serum, in blood. And someone asked the speaker, how much sample do you need to do this incredible analysis? And he said, 100 or 200 microliters. You know, it's just, anyway, I thought, yeah, we can do that. So, but they, you know, they had a very good strategy. So over the last, I'm not sure how many years, I want to say 10 years, they've really discovered, you know, how can you get to the important biomarkers in blood? And, you know, first step is get rid of those very, very prevalent things, because that if you don't, that's all you'll see. And then how do you need to concentrate it further? So all the, like, the nitty gritty sample prep, and then you've got data. Okay. Good. Okay.
Well, since we do have a little bit more time, speaking of putting people on the spot,
one of the things I was thinking that perhaps if Terry wouldn't mind, come up and just give us some ideas, because again, a lot of these wonderful ideas do take resources. And if Terry might have just some ideas or plant some seeds about how we could proceed thinking of small grants, larger grants, developing those funding mechanisms so that we could actually put these brilliant ideas into place. What do you think, Terry? Off the cuff. Yeah. You can do that.
Thank you. Okay. So I think for me, this last year has been really fascinating. Pam and I, you know, we were sitting in our office one day and we were brainstorming, and she said, you know, might be interesting to find out what biology's doing. Can you go find out? And I had the privilege of going to meet with Julie Oxford, and she spent a generous amount of time with me. And I think one of the things that is most difficult maybe for us, especially when we're siloed in our disciplines, is thinking creatively and finding those natural intersects. You know, she and I sat down for coffee, and I said, I'm not really sure what you do, and I'm not really sure what you guys do either. And so she just kind of went over what's going on in their departments. And so as I would hear keywords like inflammation or some of these other things, and I mentioned diabetes, and she says, oh, well, you know, that could have this component. Over coffee, just trying to figure out where research might intersect, to take your idea that you've been working on in a brand new direction has been so valuable. And from that conversation, we've had spin-offs. Jane's been in contact with some of your colleagues, and you also, about lactation, future lactation research and development. So if there's a way that maybe we could brainstorm a little incubation or user group sessions where we can just, you know, maybe we can take a field trip over to your college and sit down and listen to your faculty kind of go through what they're interested in pursuing, and vice versa, host a session over here, kind of a meet and greet. Just that exchange of ideas develops such amazing synergy. The other thing that I think is really helpful is determining how much a small pilot study runs, so that then I can have my eyes out for an appropriate mechanism of smaller funding. If it's more than we have internally, I can then look outside to the $10,000 to $50,000 range, or what those partnerships might look for. Especially in areas where we may not be known in the literature yet or have the organizational reputation. Finding out, from your colleagues' perspectives on, well, we've received this feedback on our grant applications and they identified this area of weakness that maybe we can look to march in and fill, or that I can have my eyes out as I talk to other colleagues around the country to find that good match and that good partnership and develop some of those conversations really early on. Just so we have an idea of scope and scale and who's doing what, who's leading, who might we be able to call upon for mentorship, who might we have early conversations with to bring on as a consultant as we move forward with maybe some R15 proposals that might make us more competitive in our endeavors. So maybe just having an eye along those lines. Certainly it'll be an education, I think, for all of us, and if we can get one or two in the labs to find out, what really is involved, and then maybe take some of you folks into the field so that you can, find out what that specimen collection is like, or gain access to a community that you may not have, that's mutually beneficial, I think will help frame future collaborative proposals. So just anytime we can have an interaction like this, that I can kind of know the scope and the scale of costs that we're looking to pull off even a small study, so that I can have my eyes out, predoctoral opportunities, in-services, maybe some of our folks can apply for some fellowships specifically in these areas. I think will help get us there. We've got a ways to go yet before the big feds think that we're probably worthy. You guys are much further along in that process than we are. But it's not insurmountable. And I think if we start early and speak often, we'll get there. So, in a nutshell. Anything else? Questions? Comments? And I would certainly encourage anybody. I'm happy to serve as a point of contact, although you have them in the department as well. And also our folks know me. So if you have an idea that you think may have merit, or that you don't know who to approach in another department, please come see me and darken my door, and we can do some brainstorming on what that might look like and the steps it's going to take to get there for external funding. So, okay.
I have a question.
Yes.
To what extent do you all use professional society small grants like critical care nursing, oncology nursing, American Nurses Foundation?
Sure. We've looked at A&F, and actually we've got a timeline developed to put in one in May. I think that's their next call for 2 of our researchers in end-of-life palliative care. We've submitted a Sigma Theta Tau in the past. I don't know that many of our faculty, and that would be one thing that would be really helpful to me, what their professional memberships are. I mean, I'll get a call come across my desk, and if I think it's geared for a specific area of interest, then I know to send it to that researcher and say, hey, do you have a membership in this society? But it would be so helpful for me to have a matrix so that I can go to this person and say, hey, there's this open funding call if it's not specific to an area, so I can better target our folks that way. But yeah, we are looking out to that. I think it's a wonderful intermediate step between our internal momentum grants or seed grants and getting us there to the feds, because we're not there yet.
My career got started on A&F and Sigma Theta Tau grants.
Mm-hmm. Thank you. Anybody else? What about professional societies in the arts and sciences? Do they have a fairly strong seed funding or intermediate funding that?
Several of them do. I know the Society for Toxicology. I know there are some really nice small funding opportunities, and then some mentoring. They have mentoring at several different levels, so they seem to be really organized. And I know about the American Society for Bone and Mineral Research, and I know they have some small grants too. So I'm guessing if we look at how we are
So that might be something that we can discuss. Do you have someone in your college similar to what I do that I might be able to chat with? Because I'm thinking, if we find a professional society for $10,000, but we need, 20 or 25 to do the study, might we apply in tandem with a professional society on your side.
I'm not sure we have someone that is your counterpart, unless it's Lisa Nelson. She's with Office of Sponsors.
I know Lisa well, yeah.
So, she's the individual that we all work through when we're submitting our grants.
Sure. Does she help you do any pre-submission work in terms of identifying possible opportunities for funding, or?
That's not her primary. We may not have, I know I get emails. I haven't, we all subscribe to the SMART, whatever.
Yeah.
For grants now, so. Yeah, I think we're on our own over there.
Okay, well, I mean, if I know some of your professional societies, I might be able to add those to my listservs and, see if we can find something that's to both of our benefit.
Right. That would be good.
Great. Anything else? Okay, thank you.
Thank you, Jerry.
Thanks.
All right. Well, I think we've had wonderful discussion. Is there any other comments or thoughts that anybody would like to share at this point? Yes, Cecile.
It was a very nice networking morning, and thank you for all of this on.
You're very welcome. Good. I'm glad it was good, and maybe this is just the first step. This is just a little catalyst to get some big stuff going. That would be exciting. So thank you all for coming. We appreciate your participation, and do spread the word, because we will have this on our website for folks that weren't able to participate. So thank you again. Thank you, Dr. Mitchell, and thank you all.